So I would like to do the video presentation for my case study. First, I'm going to introduce the patient I cared for. Second, I'm going to talk about GCS, SBAR, and NICE recommendation and some other literature recommendations, just to tell why they are important in terms of managing acutely ill patient. And I'm going to use the Gibbs reflective theory. So first, the patient I cared for, the name of his name has been changed to Mr. Patrick. Mr. Patrick is 80 years old. He had dyspnea after walking 10 to 15 paces. He carries artificial pacemaker, and he's suspicious of his pacemaker not functioning properly because he once said he had the same story, pacemaker dislocated, and he had to go to the operation and relocate it again. So he was very nervous about it. He said the device is not functioning properly. And his medical history showed he had heart attack. He has chronic heart failure and chronic kidney disease. He has diabetes. He had epilepsy. And he had 2 times of knee operations. So this is the whole big picture. So so Mr. Patrick came to our emergency department with his wife and daughter, and told us why he came. So because I asked. So so in my emergency department, the standard procedure and practice is that once a nurse has the first contact with the patient, he or she would do the observation to access Glasgow Coma scale. So because I think Glasgow Coma scale is very, very effective, very fast, and very easy to use, because Hoffman et al. 2016 comparison of AVPU scale and pediatrics GCS in hospital setting said that a GCS level of 3 means patient is already in coma state, and a GCS level of 8 or below needs immediate intervention, or a patient needs to be sent to the intensive care unit. And so I think it's very fast to do, because in emergency department it's all about time winning. So that's why I used this as well. But in Mr. Patrick's case, he scored 15. Everything was fine. And National Institute of Health and Clinical Excellence 2017, acutely ill patients in hospital overview said once a patient is presented to acute care settings, a nurse or medical staff has to do the physiological observations, which include heart rate, respiratory rate, systolic blood pressure, level of consciousness, oxygen saturation, and temperature. And I did all this. It was all fine. And then because he had diabetes, chronic kidney disease, that's why I wanted to know maybe they are also one of the causes why making him so tired and weak and shortness of breath, because of his potassium. Diabetes can make him also very weak. That's why I want to know further. That's why I did further test on arterial blood gas test, and I did. There was something not fine. So his pH value was only 7.2, and his electrolytes are also not normal, because NICE 2018 suggests for the in terms of managing the chronic heart patients, one has to do ECG, chest ray, blood test, urine analysis, and some others. So I did this because of NICE recommendations. As soon as I knew that these values are not fine, I called the medical doctor right away using SBAR method. So SPA method is actually not, according to Medley, can find out over whole 2015, evidence-based practice in nursing and healthcare, a guide to best practice. They said SPA is not health assessment, but it can give the patient's information, situation, background assessment, recommendation, and it's a very effective way. RANS 2013 said the same thing. It's effective way of staff communication to when a patient deteriorates and require immediate assistance. So I called the doctor using this method, saying, I told her that Mr. Patrick in room number 7 came with shortness of breath, and he has heart failure, he has artificial pacemaker, and all these, all his physiological parameters are fine, but not what is not quite right is his arterial blood gas test. I said, can you please come and do further checks with him? And then once she heard, she came right away, and then she did further tests. And after that, we sent him to the X-ray test, and there, after a few minutes, we found out that he had some fluid in his lungs. That was one of the causes why causing him shortness of breath. So we sent him. We sent him after 2 or 3 hours to the cardiac ward, just for further tests. So Paulanga 2009 also said, recognized that the patient's condition can deteriorate rapidly within the hospital setting. And National Patient Safety Agency 2007 said the same thing, that the key areas of improving how to manage the acutely ill patient is continuous observation, early recognition of deterioration, improve communication, and effective response to the concern. And Simlichman in early since 2016 said the same thing, the importance of continuous, discussed the importance of continuous monitoring and early recognition of patient deterioration. So these are very important in acute care settings, especially in my emergency department, because it's all about time winning. It's all about recognizing that the patient is not responding anymore. So this is the time where we can send the patient directly straight to operation theater or to intensive care unit, or where the medical team must come right away if he's not responding at all, or if something goes very fast. So in terms of Mr. Patrick's case, we monitor him like 2 to 3 hours until he get a bed in cardiac ward, and yeah, I think until then he had no further deterioration, because we already know one of the causes, so, and the rest are all fine. That's why we sent him to the cardiac ward for the further tests and therapy. So in reflecting what happened and what I all did, everything was fine, because I did everything according to the literature, according to the evidence-based. We knew his problem on time, and we monitor him 2 to 3 hours because of his heart history, which is not really fine. So I think if a nurse or medical professional did all the things suggested by all these literatures to follow the evidence base, I think we can really manage acutely ill patient successfully. Thank you so much.